My name is Najo. I'm a third-year internal medicine resident from Idaho Health, Orlando. Today, I'm going to share our QI project, optimizing SGLT2 inhibitors in our residency continuity clinic. SGLT2 inhibitors have revolutionized the treatment of type 2 diabetes with cardiovascular and kidney disease. In large randomized clinical trials, SGLT2 inhibitors reduced major adverse cardiovascular events in established ASCVD and/or CKD and reduced the risk of hospitalizations in heart failure with reduced ejection fraction. Multiple guidelines from different specialties have recommended SGLT2 inhibitors in eligible patients. We conducted this project and are aiming to optimize SGLT2 inhibitors, therefore to close or minimize the gap between the guideline expert consensus and real-world utilization. We take three-step approach, and this is the stepwise algorithm. So in step 1, we screened patients who are more than 18 years old with type 2 diabetes and have at least one of the following conditions, including established ASCVD, heart failure with reduced ejection fraction less than 40%, or CKD with eGFR more than 30. Our aim in this step is to find out how many patients are already on SGLT2 inhibitors. In this way, we can get an idea about the baseline utilization rate. So for those already on SGLT2 inhibitors, nothing needs to be done, and patients will continue to follow up with a primary care doctor. For those who are not, we review patients' chart carefully, learn about patients, gather information, then reach out to primary care doctors. We have conversation and discussion with primary care doctor about indication, contraindication, dosage, caution, side effects. We work together to decide if a patient is a good candidate for SGLT2 inhibitors. After physician-patient discussion, if patient wish to initiate, we're going to start SGLT2 inhibitors, and they'll follow up with PCP, monitor response to therapy and side effects. For those who haven't started, so we're going to go to step 3. We're going to identify what is a barrier. Once we know the barrier, we know how to improve. So we screened patients from June 1st, 2021 to December 30th, 2021 in our clinic. We screened 244 patients. Finally, 168 patients were included in our project. 39 patients are already on SGLT2 inhibitors. So we calculated the baseline utilization rate is 22, 25, and 21% in CKD, heart failure with reduced ejection fraction, and ASCVD subgroups respectively. And the overall baseline utilization rate is 23.2%. So the red portion are the baseline utilization rate in different subgroups. And so after above intervention, we were 24 more patients were studied on this medication. So this brought the utilization rate from 23.2% to 37.5%. So we increased about 15% here. In patients who have indication but haven't started SGLT2 inhibitors, we randomly chose 50 patients and performed the cost analysis. Our results showed that 20% patients were due to financial issues, 12% due to disease progression, 4% due to concern about side effects, and another 20% due to loss to follow-up. So based on above results, we can tell that the baseline SGLT2 inhibitor utilization rate was 23.2%. And we increased the rate from 23 to 37.5 and improved patient care. Based on the cost analysis, the main barriers are financial issues and loss to follow-up, and the patient's unwillingness to start new medications due to well-controlled A1C. And so based on it, we'll continue to strengthen patient education in terms of the benefits of SGLT2 inhibitors, reach out to loss to follow-up patients, and try to resume care. In further studies, we'll probably expand patient population by including non-diabetic patients, and we'll probably consider to include heart failure with middle range and preserved ejection fraction. Thank you for listening, and have a nice day.